My talk will be very brief and I'll be dealing with just a few points on how to manage a patient medically as well as surgically. So this is a brief study done by Jay and Murdoch, who estimated the average time for an untreated disease to progress into an advanced stage. This was determined by the baseline uncorrected IOP. So if a patient presented with an initial IOP which was uncorrected between 21 to 25, it took about 14 years to progress into an advanced stage of glaucoma, that is involving the central 5 degrees of fixation and absolute scotoma. If the uncorrected initial pressure was between 25 to 30, it took about 6.5 years. At the same time, if the uncorrected pressure was over 30, that same thing happened in just about 3 years. So the change is exponential. That is why the most common risk factor that we can correct is the intraocular pressure. Ideally, it should be within the low teens or even in certain cases of advanced glaucoma into single digits. So this has been shown to be the strongest risk factor which we can correct, the modifiable risk factor. And the AGES study, which basically dealt with advanced glaucoma patients, showed that typically patients who maintained a mean IOP of about 12 mm were the ones who did not progress. Now, along with just the mean IOP, there are certain other measures that we should take into account. One is the IOP peak, diurnal short-term variation, as well as visit-to-visit long-term variation. So, DVT should routinely be done in most patients, which record all these other features too. And then patients who have recorded IOP peaks outside, before we initiate any sort of medical therapy, the most important thing is to instruct the patient on proper application technique, because that will ensure that compliance as well as the efficacy of the drug is fully attained. Compliance should always be tested. There are certain clues that can be used for each medication, which I will tell you when I'm dealing with them, on how to ensure that the patient is compliant. Now, before we initiate any drug, first of all, we need to establish its efficacy, and we can do something called a unilateral drug trial, in which a drug is initiated typically in the verse eye, and a patient is asked to review within the peak IOP period, after the peak IOP is attained. If based on the IOP response, we can decide if that drug is a good choice for this patient. So ideally, if the target IOP is attained, the same drug can be initiated in the alternate eye. If the IOP reduction is less than 15%, we have to discard the drug, or if it is causing severe side effect profile. If the IOP reduction is greater than 15% than baseline, but it is still not attained the target IOP, then we can add a second drug to the combination. And in certain patients where a follow-up would be difficult, we can also initiate a reverse trial wherein the drug is initiated in both the eyes, and after the peak effect is attained, a patient can be asked to discontinue the drug for the washout period to reassess pressures in both the eyes. So this is just a rule of thumb. If you need about a 20% IOP reduction from baseline, beta blockers are good choices because they are relatively cheap, provided the patient has no systemic side effects to preclude these. Another important history that we need to take is if the patient is on systemic beta blockers, because they have an ability to reduce the efficacy of a topical beta blocker by about 80%. So most patients on hypertension, this will become a significant factor, in which case we may need to consider a prostaglandin as first line. So for 30 to 35% reduction, a prostaglandin, any of the prostaglandins, latanoprost, travoprost, tafluprost can be initiated. And generally, if 35% or more lowering is required, a combination therapy may need to be done. Systemic beta blockers, generally the IOP lowered by the first medicine, it tends to be the highest. That is why the first choice has to be very important, because any subsequent drug that we add, the reduction will not be proportionate. And it has been shown by multiple studies that if a diurnal variation in pressure done on a DVT exceeds 8 mm, it is a very strong independent risk factor for progression. That is why I was stressing earlier that a DVT needs to be done routinely in all patients. PGA and combinations of either carbonic anhydrase or alpha-2 agonists with beta blockers typically tend to reduce, along with the peak IOP, they tend to reduce fluctuations much better than beta blockers alone. And it has been shown that brimonidine and bitoxolol also tend to have a strong degree of neuroprotective effect. This can be because of release of certain neurotropic agents as well as improving the blood supply to the optic nerve. Now certain small conditions wherein we would not prefer drugs is if a patient presents with a history of bronchial asthma, non-selective beta blockers should be strongly avoided. Betaxolol is preferable, but in many patients that also can induce an attack. So ideally, a beta blocker should never be the first choice. If you need an add-on, then a betaxolol is preferable to a timolol. Bradycardia and bronchial disease are two absolute contraindications. Initially, congestive cardiac failure was considered to be a side effect, an absolute contraindication. Now it is a relative contraindication because oral beta blockers are routinely advised. If a patient presents with a beta blocker allergy, typically the allergy is to the preservative to the beta blocker. They rarely develop an active allergy to the active component. In prostaglandins, we need to avoid them in any case of an inflammatory glaucoma if the patient has a previous history of herpetic keratitis, as it can cause a reactivation, and if there is a compromised posterior capsule, especially if the patient presents with a cystoid macular edema. In terms of cosmetic or cosmesis, it is very important to consider initiating a PGA in a patient with a light colored eye. Typically a blue, brown or a hazel eye, they have a high risk of color change. And this becomes extremely important, especially if you're initiating it in a unilateral way, in one eye. Periocular skin pigmentation can also be a significant problem. Topical carbonic anhydrase inhibitors should be avoided in patients who have a compromised endothelial status. Alpha-2 agonists can cross the blood-brain barrier, so you should typically avoid them in infants. And generally in patients up to 8 years, I don't prefer using an alpha-2 agonist. They can also cause significant somnolence, but this side effect can be reduced by a little bit of NLD occlusion and eye closure. And the follow-up schedule, again, a rule of thumb is a pre-perimetric or an early damage glaucoma can be followed initially 6 monthly. Once it has been recorded as stable on repeated DVTs and perimetries, then it can be made a yearly follow-up. Moderate damage glaucomas can be followed every 6 months, and late severe glaucomas once in 3 to 4 months. Now I'll just go briefly onto surgical treatment. There are multiple surgical options which target different areas of the eye. So the standard outflow techniques are increasing the outflow via a new channel, that is a trabeculectomy, the express shunt, or using a glaucoma drainage device. We can also augment the trabecular flow using newer techniques like the Kahook dual blade excisional goniectomy, trabectome canaloplasty, or a excimer laser trabeculostomy, or the eye stent, the trabecular micro bypass stent. The third is the uveoscleral outflow, which is a little more controversial and dangerous, the Soak's code shunt, and the CyPass implant, which has now been discontinued. So trabeculectomy has been shown to be associated with a lower peak as well as lower mean IOP as compared to medical therapy. So this is one advantage it has over standard medical treatment. And the average survival for a trabeculectomy is shown to be about 60% without medicines at 20 years and 90% at 20 years with additional medication. So certain preoperative measures that we can take to ensure success for a trabeculectomy is, first is most important, is to check the extent of conjunctival scarring on the slit lamp. This can be done either with a earbud or even with a finger. We have to check the mobility of the superior conjunctiva before planning a trab. The risk of a wipeout or a snuff out, though it is very rare, reported incidences between 1 to 7% only, should always be explained in all patients with advanced glaucoma. And topical steroids should be initiated to reverse any histological changes in the conjunctiva before surgery. Anesthesia, the best route of anesthesia for any patient with a moderate to advanced glaucoma is either topical or subtenons, because peribulbar or retrobulbar can cause significant rise in intraocular pressure, which can itself initiate a snuff out. And ideally use adrenaline-free lignocaine. Intraoperatively.
Excuse me, sorry. Kartik, please summarize.
Yeah. So intraoperatively, both phonics and limbus-based surgeries do equally well. MMC augmentation is much better than 5-fluorouracil. Certain speculums like the Lieberman speculum are good. And conjunctival handling, the most important thing is using the right forceps. So the Hoskins forceps is what I always recommend. Never use a toothed forceps. IOP lowering should be slow, either with preoperative mannitol or a slow decompression using a side pot. And keep the AC maintained to prevent an intraoperative suprachoroidal. Scleral flap should always be half thickness and should adequately cover the ostium on both sides. And the flap closure, typically use a slip knot technique because it helps in adjusting the suture tightness. And post-operatively, ideally advanced glaucomas operate early in the morning so we can see them quickly later to check any early complications. Cycloplegic drops like atropine I generally advise only if there is significant inflammation or if the patient has a penchant for going for a angle shallow chamber. Okay. Just quickly in cataract surgery patients, it can be done. You can select aspheric IOLs, but if
this topic will be covered by Dr. Devendra, sir.
Okay, cataract.
Cataract.